Hello, this is Dr. Quinn Capers IV. It's my pleasure to talk to you and share some thoughts with you about implicit bias and the mitigation of implicit bias. I'd like to start out with these photographs. As you look at these photographs, I ask you a simple question. Which one of them make you feel comfortable and which might make you feel a little uneasy? Now, it could be that your answer is none of them, but it also could be that as you look at certain of these photographs, that you automatically, unconsciously even, feel comforted, and that others might make you feel discomfort. That feeling has everything to do with your experiences and what you have been exposed to. If one of these photographs looks like someone you've had very pleasant and positive interactions with, then when you look at someone who looks like that, you will unconsciously feel pleasant. On the other hand, if one of them looks like somebody that you've had unpleasant interactions with, then you will have an uneasy interaction that is brought up in your mind. We call these implicit biases, and it turns out that we all have implicit or unconscious biases. And Janice Sabin and colleagues in 2009 showed us that physicians are not unique, and physicians have implicit biases. They tapped into a computer database to look at the results on the computer-based implicit association test, which has been taken by millions, which uncovers our unconscious or hidden biases. And what they found is that physicians have the same level of unconscious negative racial, negative gender biases as do people who are not physicians. So I want to talk about the fact that in healthcare, we all have implicit biases, and it is important to be aware of that and to be honest about it. And we've given many implicit bias workshops throughout the years, and one of the things that we do at the end of the workshop is we ask our participants to make an anonymous pledge to use one of the strategies that we've discussed to reduce implicit bias. And I'll just share some of those with you. And I want you to keep in mind, these are pledges made by physicians or scientists working in academic medicine. One person says, I've developed bias against black people from living in a heavily segregated community where relations between white and black people are poor and there's a fear of violence. Another person says, I have an implicit bias against people with multiple body tattoos. Yet another person says that they have a bias against people with certain religious views. And then finally, someone says, I have a bias against quote unquote typical Trump supporters. So these are physicians and these are scientists that are doing research and taking care of patients. And so it is so important that we acknowledge that we all may have implicit negative biases. The good news is that we can overcome those biases and be sure that we're treating everyone fairly. One way to see what are your biases is to take this publicly available implicit association test, which you can take by going to projectimplicit.org. It turns out that the results on those tests have been at least associated with discriminatory behaviors in the education system, the criminal justice system, and in the healthcare system. So where do these biases come from? They come from images that are all around us. So as you and I get up in the morning and go about our day, we are bombarded by images and by stimuli. And I'll give you some examples of where some of these biases come from, because these stimuli form a foundation in our unconscious mind that can lead us to have certain associations. Here's an example. What you're looking at now is a billboard in Savannah, Georgia. And on this billboard, you see a picture of 3 white males wearing surgical caps and masks. The only print on the billboard says all cardiothoracic surgeons look like this. That's it. That's all that's on the billboard. Now, it turns out in the minds of this company, they have a reason for that billboard, but I'd like you to think about the little girl who sees that billboard every day, or for that matter, the little boy of color who sees that billboard every day. If they see it enough, the unconscious mind will say, this is the truth about the world in which you live, and then they will live their life accordingly. Here's another example of unconscious biases and the impact they can have. A police department in Michigan was having a tour, and they were giving a tour to Boy Scouts. And what the Boy Scouts discovered, and this blew up on social media a little bit, is that in the shooting gallery, where the police officer trainees were being trained on how to shoot their firearm, the target practice was photographs of young black men. Young black men wearing hoodies, wearing baseball caps backwards, with a scowl on their face, and carrying a gun. So that's how, in this police academy, police officers in training were learned how to shoot their gun by shooting at images of young black men. It's not too hard to imagine that if that is your training, that when you then graduate from that police academy, that you might have a certain bias that makes you respond in a certain way. So the images around us are responsible for these biases, and there are many biases in academic medicine, in clinical research, and in our clinical care. And some of them, based again on images that are all around us, tell us that unconsciously we should associate men with leaders, or women with homemakers, or black men with danger, Hispanic patients with being less compliant with recommendations. So with all of the images around us, and with these being some of the possible associations that we can have, it's very important for those of us participating in research and in clinical care that we are aware of this issue, and we know that there are ways to mitigate the impact of some of these biases. Now, in academic medicine, how might some of these biases play out? We participated in a research study at The Ohio State University, where at the time I was the dean of admissions in the medical school, where we had our admissions committee, which was a large committee. We had them all take some of these implicit association tests, and what we found was that more than half of that committee had unconscious negative biases about black people and unconscious negative biases about members of the LGBTQ plus community. And this slide here shows you that 52% of the women and 64% of the men on that admissions committee had, for instance, a result on the IAT called implicit white race preference, which means unconsciously I associate a white person's face with good and positive things and a black person's face with negative things like danger, fear, violence, misery, etc. Now, how about after getting into medical school, when those medical students are applying for residency and fellowship programs? Is there evidence that there is bias in that selection process? And the answer, of course, is yes. I'd like you to take a look at these pictures as I ask you this simple question. If these are interviewees for your residency program, if they all have identical academic credentials, the question is, are they on equal footing? Are they equally likely to be accepted into your program? And let me give you some background data that might argue in a certain way. A study in 2020 with physicians who are in charge of selecting residents in a radiology residency training program participated in the study where they looked at applications of applicants. And if you participate in this, the selection of applicants for residency, you know that a photograph is a part of the application. So the researchers made some of the photographs people who looked to be of average size, and some of them people who were overweight. And they mixed up the credentials so that some had very strong academic credentials and some had mediocre academic credentials. They then had those radiology residency faculty members to rate the applicants in terms of how competitive they were. And what they found was that for identical academic credentials, the applications whose photographs appeared obese or overweight were rated as less competitive for the residency program. Here's another study looking at something similar, but with faculty who pick out and select from applicants to orthopedic surgery residency programs. In this experiment, applications that 1 year previously had been reviewed and selection processes made were brought back, those same applications, and reviewed by the same faculty. But in this instance, the race of the applicant and the photo were redacted. So, in other words, these faculty were reviewing applications they'd already reviewed a year ago, but they couldn't see the applicant because the photo was taken away, and any reference to race was taken away. The results were interesting, and what they showed, when you looked at the minority applicants, that the rating from 1 to 10, with 10 being the highest, for the minority applicants pre-redaction, in other words, when you could see the photo and see the person's race, their average rating was 7.4. When they brought that same application back and hid the photo and hid the race, the score actually went up. When you looked at the white applicants, when you could see everything, the faculty rated them on a scale of 1 to 10, 8 on average. But when they brought those same applications back a year later and took away the photo and redacted the fact that the applicant was white, the scores actually went down, indicating that the race of the applicant actually does have an impact on how the faculty member rates their competitiveness for their program. So now I show you these pictures again and ask you the same question. If all of these people have identical credentials, do they have an equal chance at getting into a residency program? The evidence tells us that they do not. And that is not because the faculty reviewing these applications are quote unquote bad people. It's because they are human and they have biases that are unconscious, outside of their awareness, outside of their intentional control. How does bias work in scholarly and scientific publications? Another very important aspect of academic medicine. I'd like you to consider the process of having a scientific paper reviewed and ultimately published. For many journals, the name is not redacted. And so take a look at these names. I'll just give you a minute to look at these names of authors. Let's pretend these are the first authors of papers that have been presented to you, and you are a reviewer for a scientific journal. There is evidence that when we hear a name, if that name sounds to us international or foreign or ethnic, that it can trigger some unconscious negative biases. If the name sounds like it's a typical name of a woman, it can trigger some negative biases. So take a look at these names and just think about the biases, whether they are positive, this is going to be a really good paper, or negative. This paper is probably not going to be as strong if those kind of feelings are possible. The research tells us that they are. Now, let's look at adding the institution, which is also something that is often visible. We have biases about an institution, correct? I mean, if this paper is from Harvard University, from Yale University, it must be a good paper. Or if it's from an institution that I've never heard of, then maybe the science is not as good. So here is something along that same line, this time looking at the review of research grants. In this paper by Nakamura and colleagues, 1,200 NIH grants that had already been reviewed and successfully awarded an R01 research grant from NIH were brought back and reviewed by a group of NIH reviewers. And in this experiment, they, on the re-review, and again, remember, all of these had been successfully approved and given money to conduct NIH research. But when they brought them back, again, they redacted the race of the applicant. They looked at 400 applications from black researchers, 400 from white researchers, and another 400 randomly selected from white researchers. Here's what they found. Remember, all 1,200 had been successfully awarded research grants. They found that applications from the white investigators scored better than those from the black investigators. But they found that when they redacted race, the redaction made the scores for the white investigators go down. So in other words, when the reviewers didn't know that the investigator was white, they were given a lower score. So, and again, not because these reviewers are quote unquote bad people, but because of the images around us, because of the stimuli around us, we all take in these things and they can lead us to have these unconscious negative biases. Finally, how about clinical care? I'm a cardiologist, so I'm going to use a cardiology example, if you don't mind. What you're looking at now is a slide showing you the use of new interventional cardiology procedures that can be life-saving. Transcatheter aortic valve replacement, or TAVR, transcatheter mitral valve repair, TMVR, and left atrial appendage occlusion, which is a device that is inserted in the heart that can protect patients from having a stroke. And what you see is that while all of these new technologies have a very beneficial effect on health, that the utility of these in our country is that blacks and Hispanics are significantly less likely to be a beneficiary of these new techniques, these new procedures, these new devices. Now, there's a long list of reasons why that might be the case, but there is evidence that tells us that bias on the part of the physician may be one contributor to this disparity that we see. These disparities in cardiovascular procedures are not new, and the first studies to show them were way back in the 1990s and have continued in the medical literature up until the 2020s. So there's been now 4 decades of papers in the published literature showing that there are racial disparities in the use of therapeutic cardiovascular procedures. What does bias have to do with this, if anything at all? Well, here's an example, and this is an old study, but it's an important one. And in this study, physicians were actually shown a video of an actor playing the role of a patient having chest pain. You're looking here at those actors. The actors all read an identical script. The script read this way. It said something like, "I'm having chest discomfort. It feels like a ton of bricks sitting on my chest. I couldn't breathe. I broke out in a sweat all over my body, and my left arm was numb." Any physician would know that this patient is in trouble, and it sounds like they might be having a heart attack. Well, each physician in this study only saw one of these actors, and then they were asked a series of questions. One question was, would you refer this patient for a heart catheterization procedure, which is the procedure that we do in cardiology to diagnose whether or not you have blocked arteries in your heart, and then to fix those blocked arteries if we find them. The research showed that the white males were more likely than anybody else to be referred for the heart cath. The white females were second most likely. The black males were third most likely, and bringing up the rear were the black females. So in other words, when a black female reported chest discomfort, shortness of breath, a drenching sweat, and a numb left arm, she was significantly less likely to be referred for a heart catheterization procedure than when a white male said the exact same thing. Now, I'm sure the physicians who participated in this study going into it thought that they have no biases, that they treat everybody the same. But the results show a different story, that it is likely that even if you don't know it, you might have some gender or some racial biases, and it is possible, not a guarantee, but it's possible that that can impact patient care. The good news is that we can override our unconscious or implicit biases, and it's actually not hard to do. But before we go into some case studies where we rehearse some of these strategies, I just want to give you a little bit of data, because what you might be asking yourself now is it worth the time? Does quote-unquote implicit bias mitigation training work? And there is evidence that it does. There's evidence from a study showing that a 2.5-hour bias mitigation workshop actually improved the climate in academic departments of internal medicine. There's another study that showed just a 20-minute intervention was successful in some instances of breaking the bias that many have that leadership and men are linked together. That when we think of leaders, we think of men, and we don't think of women as leaders. A 20-minute intervention was able to, in some cases, break that bias. I've shown you our research about implicit racial bias of a medical school's admissions committee. What we found is that once we went into an implicit bias mitigation workshop where we rehearsed strategies to reduce the impact of bias, the next class that we admitted at the Ohio State University was the most diverse class ever. And then finally, we see that once again, a bias mitigation workshop in a randomized manner at the University of Wisconsin was able to result in science, technology, engineering, medicine, and math departments actually hiring more women at the end of 1 year. So if you're asking yourself, Is it worth the time to undergo implicit bias mitigation training, and does it matter? The answer is that yes, it can. So there are several strategies that we usually talk about when we talk about reducing the impact of implicit bias. One is called common identity formation. And this is when you're interacting with someone, whether it's a potential research subject, whether it's a patient, whether it is you're meeting your neighbor for the first time, look for things, ask questions to try to find where you and this person share a common group identity. That is, you're maybe from the same hometown, you both grew up on a farm, you both speak more than one language, you both like the Dallas Cowboys. It turns out if you are in that group and you find out that this person is in that group, say the group of people who like the Dallas Cowboys football team, that actually can reduce the unconscious negative bias that you have towards that person, even on an unconscious level. So find where you and this person share a same common group identity. Number two is called perspective taking, and this is just an exercise in empathy. Force yourself to see the world through this person's eyes. If it's someone that you are consenting for a research study, if it's someone that you are interviewing for a job, if it is a trainee that you are grading, force yourself to see the world through their eyes. When you do that, you develop empathy, and that's the key. Empathy actively opposes unconscious negative bias. Number three is my favorite. It's called consider the opposite. And that is when you have the evidence in front of you, pointing you to a certain decision, stop, pause, time out, and force yourself to re-review the evidence, this time looking for evidence that convinces you of the opposite of your first conclusion. We call that consider the opposite, and that has been shown to reduce the impact of any implicit biases that we might have. Finally, counter stereotypical exemplars. When you're interacting with somebody, think of someone you know that shares something in common with them that you hold in high esteem. So if I'm interacting with a trainee or a research subject or a patient, if I can imagine someone that I hold in high esteem that shares something in common with them, that will reduce my unconscious negative bias against that individual. I'd like to finish up now with some brief exercises or case studies and how we can use some of these strategies to reduce the impact of our implicit biases. For the first case, I want you to imagine that you are the reviewer for a scientific journal and a title of an article has been submitted to you. So the title is this: immunoglobulin content in the breast milk of Western Nigerian mothers is not affected by malnutrition. And so, again, just think what you want to do. Your job is to be unbiased and to give an unbiased review. But as I've told you, there is data that before you even begin reading the paper, your brain might be taking you in a direction of saying this is going to be a good scientific paper or this is not going to be a good scientific paper. Let's look at the authors of this paper. The names are Ubuntu, Afolabi, and Ijeoma. And the institution is the Obafemi Awolowo University Teaching Hospital in Nigeria. Your job is to give an unbiased review, and remember, you haven't even started reading the paper yet, but there are some potential biases. There's some things here that can bias you. First, the names of the authors. Do they sound ethnic? Do they sound international? Do they sound like they're from a country different from the country that you are from? It is possible that that can trigger a negative bias. The institutional affiliation. Have you ever heard of that institution? Does it sound to you like an institution that is a research powerhouse that's capable of rigorous studies? If it doesn't, that can start to lead you in a bias against the study. And it's not likely to help increase the readership of the journal. You might be thinking that this paper about protein content of breast milk in malnourished mothers, that's not something that a lot of people want to read about. So general ideas about the importance of the work can also further bias you. So your biases might be that the authors are international, that this is an obscure medical center. They're not likely to have the resources to do good quality science. Those names sound like they belong to people who are black, right? Black, Nigerian, and we don't know Nigeria to be a place that does high quality research. At least this might be what you're thinking. And again, protein analysis of milk samples, not very elegant research in 2020s. That's kind of 1990s level research. These might be things that before you even begin reading the paper are negatively biasing you. So, as you take a look again at this study, I want to juxtapose it to another study that, let's say, you've been asked to read. And that is downregulation of cytoskeletal protein C confers resistance to pacing-induced cardiomyopathy in myocardial cells of ApoA1 knockout mice. The authors are Smith, Johnson, and Carter, and they're at the Washington University in St. Louis in the United States of America. So I want you to think about how the name of the article and how the names of the authors potentially could bias you in one way or another. Remember, biases aren't always negative. Biases can be positive. In this case, the authors' names, they sound American. They sound English, or like at least these are native English speakers. That might trigger a positive bias in you. Washington University of St. Louis is a research powerhouse. Lots of good science comes out of there. And it's a basic science study as opposed to a clinical study. And creating knockout mice, that's very difficult. That's very elegant science. And so again, before you've even started reading the paper, you might already be thinking, our journal is going to accept this paper. So think about how words can trigger these biases. Consider the opposite can help here. Consider, after you've done your review, of just the name of the title and the authors, that good science occurs everywhere. It knows no geographic boundaries. Scientists from all origins are capable of producing high or even low quality science. And institutions, even institutions with a legacy of good science, can have lapses. And it's also possible that low resource institutions are capable of high quality science. That is how we can use that consider the opposite to help us in that bias in scientific publication. Now let's talk about clinical care. In case 2, I'm going to say you are a nephrologist, a kidney specialist, and you sit on the kidney transplant committee. You and your team get to decide of all the patients with kidney failure who is going to be referred to get a kidney transplant and almost a new lease on life. And this is your patient. This is Mr. Jenkins. He's black, he's 41 years old, he's been on dialysis for 3 years, he's got a history of medical noncompliance, he's married, has 2 sons, and he works at the printing press. Mr. Jenkins does not have reliable transportation. You and your team have a decision to make. So what implicit biases might impact your decision? Well, we've used this case, Mr. Jenkins, in multiple bias mitigation workshops. And what I have here in red are the things that people tell me might trigger their negative biases. The fact that he's black or African American, the fact that he has a history of medical noncompliance, and the fact that he does not have reliable transportation. So already you are starting to have some negative biases about whether or not he will be referred for a kidney transplant. So what can we do? We can do common identity formation. That is, we can think of where we and Mr. Jenkins share something in common. Simply finding that out, where you and Mr. Jenkins share a common group identity, can reduce your negative implicit bias. Perspective taking. If you find that you force yourself to see the world through Mr. Jenkins' eyes, what is it like to be him? What's it like to be a father and on dialysis and to really be wondering about, am I going to live to see my kids grow up? What does that feel like? If you go through that exercise, develop empathy for Mr. Jenkins, that will reduce some of your negative bias against Mr. Jenkins. Consider the opposite. So you've done your first pass, and you might be tempted to vote no, based on what we've already discussed. Doesn't have good, reliable transportation, a history of not taking his medications. But before you make that decision, pause and consider the opposite. Maybe when you talk about the fact that he's been married 19 years, that means he keeps a commitment. He's had the same job for a number of years. That means he could show up on time and get the task done. So maybe if you were to implore upon him and talk to him about how important the medicines are, maybe he would be a good transplant candidate. Now make a decision, because you've considered both sides. That has been shown to reduce the impact of our unconscious negative biases. And finally, counter stereotypical exemplar. Imagine someone you know that shares something in common. Do you know someone who's on dialysis, who has kidney failure, who has a chronic medical illness that you hold in high esteem? Think of them when you're thinking of Mr. Jenkins. That can reduce your unconscious negative bias against Mr. Jenkins. Final activity. Now you are about to pick a new leader for the cardiac cath lab at your hospital. And your candidate that you're considering today is Dr. Lee. As you see, Dr. Lee is a woman. She's Chinese. She has been the director of the cath lab and the research at a typical hospital before coming to yours. She was kind of fast-tracked in her education. She finished high school at 14, college at 17. She had her doctorate by 21, her MD by 24, and she was the youngest editor-in-chief of a major journal. She migrated to the U.S. from China when she was 8. She is an elite chess champion. She's married, has 1 child, and one colleague at her previous institution said she's blunt but brilliant. And she once wrote an essay criticizing legacy admissions in American universities. So you have a decision to make. So first we start off by saying, what are some biases, what are some things or some traits about Dr. Lee that could trigger our negative biases? And so we've used Dr. Lee in other workshops, and let me tell you what comes up with her. People have been in these discussions have said honestly the fact that she's female, the fact that she's Chinese, the fact that she went through school at a very rapid pace might mean that she is difficult to relate to, the fact that she's an immigrant, and this saying from a previous person that worked with her that she's brilliant, but she's kind of a hard charger. All these things might negatively bias you against Dr. Lee. And so we go through these strategies again. Common identity formation. What do you and Dr. Lee share in common? Once you acknowledge that, that reduces your bias. Perspective taking. What's it like to be her? What was it like to be the youngest person in her high school class, the youngest person in her college class, the youngest person in her medical school class? Feel that. What was it like to be an immigrant, especially right now in the United States? Once you feel that, you develop empathy for her. That reduces some of your unconscious negative bias against Dr. Lee. Consider the opposite. Maybe you're going to vote no on her candidacy because she's a hard charger, she's a little bit of a rebel. She wrote this essay against the way American universities do this legacy admissions. But now consider the opposite. She clearly is very intelligent. She clearly is very experienced, and maybe we need a leader who will shake things up. Now you think about that, she might be a good cath lab director, and so considering the opposite, now you make a decision, and that can mitigate the impact of your biases. And finally, counter stereotypical exemplars. Do you know someone who reminds you of Dr. Lee? A woman who is a high achiever, who's had to work very hard to prove herself, that you hold in high esteem? Well, if you think of that person, that will bring your negative bias against Dr. Lee down. So that's how those strategies work. And in conclusion, what I want to say to you, especially as we think about how biases can impact our clinical research, think about the fact that we all have biases. It's just how our brain works. Having bias doesn't mean that you've discriminated. It doesn't mean that you will discriminate, but it means that you might, and you might unknowingly discriminate. So it's important to be aware of these issues and to know that there are ways to, in the moment, mitigate our implicit biases. In clinical research, there are multiple opportunities for the biases to impact our interactions with patients. As we consult with patients, as we talk to them, as we follow them up, and we want to actually get them to consent to be in our studies, our unconscious biases can actually impact how we interact with them. That's why being aware of biases and knowing how to mitigate them is very important. We recommend that all principal investigators, all research nurses, all research coordinators be aware of implicit bias, be aware of how to mitigate these strategies, and actually rehearse some of these implicit bias mitigation strategies. I hope this has been helpful to you. Thank you very much for your time and attention.